The journey began way back in 1992 when a series of cases was published by Bridges and Locke way back in 1992. The title in the journal was Transcatheter Closure of PFO After Presumed Paradoxical Embolism. So this was a series of 36 cases which set the ball rolling. 5 years down the line, it was a first in Switzerland when Kurt Amblatz and Meyer did the first PFO closure using the Amblatzer PFO device. Fast forwarding to 2016, the scenario had changed. This is the practice guidelines from the American Academy of Neurology. They said, reviewing all the literature till then, that the PFO closure was useful to reduce recurrent stroke, but with a rider of caution saying it increases new onset AF. And also, there was a 3% morbidity to the procedure. So what did they recommend? They recommended that it should not be used as a routine, but reserved for cases where there is recurrent stroke despite optimal medical treatment with a small procedural risk. Now, that was Neurology 2016. Now, the very next year was this article and editorial in NEJM, the tipping point for patients for patent foramen oval closure. What was the tipping point? Did they say no PFO chapter is over, or did they welcome with both hands? So this was a very controversial statement, provocative statement made by the editor saying that it seems reasonable that the presence of a PFO and a sizable endoatrial shunt should similarly no longer result in the categorization of a stroke as cryptogenic, leading to the fact that it might be even causative, just like a 50% carotid stenosis or atrial fibrillation or a cardioembolic source. So what was the tipping point? The tipping point was these 3 trials which was published in September 2017 in the same journal, NEJM, in the year September 2017. Reviewing was the 3 negative trials, namely the closure, the PC, and the RESPECT trials in the preceding years, and the current trials, namely the GORE reduce, the close, and the RESPECT. Now, what was different was, why did this suddenly change? A few insights in this would be the inclusion of lacune stroke in the closure trial, which was predominantly a negative trial, and also the duration of follow-up. So with this in mind, a large meta-analysis was performed, and this was published as recent as March 2018 when they clubbed all these studies. And what was the take-home message? It found that there was an absolute risk reduction of 3.2% with a number needed to treat of 31 only to prevent recurrent stroke. So this was a big change in the thinking and a paradigm shift. So this was not without complication. The previous trials, they said the TIA rate and the major bleeding was pretty much similar, but there was a trend towards more AF in the group of patients which had PFO closure. Following this, now having established that PFO could be even causative, they described a score called the ROPE score to identify the prevalence of PFO in patients with cryptogenic stroke, especially who are young. It is called the risk of paradoxical embolism. The score went from maximum of 0 to 10. What was interesting about this score was absence of a conventional risk factor was scored 1, and the lowest age group patients had the maximum weightage. So what does that mean? So it's essentially to say that as the age on the lower age group with no conventional risk factor, the prevalence could be as high as 73% of PFO in patients with cryptogenic stroke, and the attributable risk could be as high as 88%. But on the extreme right panel also shows the recurrence of rates in this subgroup. Compared to the other subgroup, this is much lower. But bear in mind, this is a subgroup of patients who are 20, 25 years old, who have a long, lengthy lifespan beyond this index event. So to sum it up, a score of 10 at a very high probability of almost 73 to 80% of a PFO being the causative agent for stroke, whereas a score of 0, usually a patient more than 70 years of age and with conventional risk factors, the prevalence was only around 19 to 26%, and the probability was almost 4% only. So this brings us to the current family of devices which are at our disposal for closing a PFO. I'm familiar with one such device, which is the Amplatzer device, and I used a few premieres when I was abroad. So the two family of devices, basically the dedicated PFO occluder device and the crib reform where we encounter multiple fenestrated aneurysmal intraatrial septum. So this is the spread in the country. So we had around 28 closures in 2015. In 2016, the number had reached 38, and 2017, it was almost 71. And these were the centers which were offering PFO closure as a program. And the commonest device which was used was the 25 mm, which has been the trend world over. So I would like to, with these in mind, I would like to share the CMC experience. So patients referred for PFO closure over a period of almost 2.5 years. The mean age was around 38, mostly males, 67%. 100% of them had transcranial Doppler positivity. And when we interrogated them with a very dedicated protocol, we found that PFO was present in almost 65% of the cases. The mean PFO size was 2.1. I put the mode there because there was an outlier of 10 millimeters which sort of tilted the trends. And 70% of their PFOs were associated with a small tunnel, and 20% had intraatrial septal aneurysm. So this is the proforma which we use for evaluation, which includes the indication, the measurements, the shortest distance to the defects from the aorta and the SVC, the type of aneurysm, and a dedicated dynamic protocol where we involve both color flow and Valsalva imaging with Doppler as well as with contrast bubble. So this is a typical case where it was referred. You can see on the left panel a small PFO showing both right and left. The blue shunt is from the left atrium to the right atrium, and the red one is from the right atrium to left. On the right panel is the one where the flapping PFO with the Valsalva showing the bubbles going from the RA to the LA. And this is what I call the slide for the non-believers, people who don't believe that PFO can produce harm. This is a thrombus actually squirreling through the tunnel going to the left atrium. This was a timely catch. This patient presented to us with a systemic embolism of his lower limbs requiring thrombolysis, subsequently had an embolectomy, and 3 months after anticoagulation, we went ahead and closed his PFO. So this brings us to how to choose the patient. So this is the team concept again, much alike to the TAVI team. We have a cardioneurology team in our institute. And what is different from this is here the referrals are essentially from neurology and neurology only. Even if we catch upon a patient with an echo PFO dropout, we never advise or seek the patient for a review. So, and all these patients had a positive transcranial Doppler study. The most commonest indications were cryptogenic stroke, some with complex migraine. The data is not very robust, with a little bit of mostly aura and systemic embolism. But we had to demonstrate a PFO with a demonstrable shunt. This is a device which we use. It's a self-expanding device, much like the ASD device. Slight difference, the LA disc is smaller, double disc design, a flexible narrow waist, and it is flexible because it has to align the tunnel, whatever its shape is, and it has got nitinol interwoven polyester to promote occlusion and endothelialization. So based on two factors, one is the presence of an intraatrial septal aneurysm where we would want to choose a larger device, and also the restricting factor is the distances from the defect to the SVC and to the aorta. So this is how we size it, from the defect to the aorta and from the defect to the SVC in the aortic short axis and the bicaval view. And we choose a defect which is the right atrial disc radius is less than the shortest of these diameters. So mostly we end up using a 25 mm device, and most of these devices are compatible with the 8 French system, the largest one being compatible with a 9F system. So we use conscious sedation, fentanyl imidaz, transesophageal echo, and occasional case and ice, femoral vein, 5,000 units of heparin to maintain the ACT between 250 to 230. Crossing the defect is pretty simple with a multipurpose one, and you pass a straight wire, just like how you do a ASD. deploy the left atrial disc, ascertain it under TE, assess the position, release the RA disc, do a wiggle, make sure it's all right. But one rider is that because this is a very, very simple procedure, you have to be very careful that you don't create problems inherent to the procedure. So de-airing is very, very important. In graphic terms, the cryptogenic strokes form the bulk of a series, and PFO was present in around 65% of the cases. In our series, we didn't find much of an association with the presence of the interatrial septal aneurysm and stroke, probably because of the low numbers. One thing was evident. As the size increased, the shunting increased. You can see the small blue bars are the ones with the small shunt towards the left panel where the device size is less than probably 1, starting from 0.5 to 10. And the 10 is the beige one. When we did the contrast bubble study, the entire LA was opacified. So the procedural characteristics, the age was around 41, the follow-up of almost 1.5 years. One patient was lost to follow-up, moved out of the country. Procedural success was 95.4, no major complications, no recurrence of stroke during the follow-up period. One patient had a residual shunt. We used the 25 mm device, an occasional case where a cribriform ASD device was used. Two procedural complications. One was air embolism, had a transient ST elevation in inferior leads, settled with oxygen therapy. Second had an atrial fibrillation with a fast ventricular rate. Peri-procedurally, we reverted with a DC shock, but didn't have a recurrence. Third, the defect could not be crossed. So this was a patient who had no obvious defect of a PFO, but we could see few bubbles traversing from the RA to the LA on Valsalva. But 15 minutes of fluoro, we couldn't cross the defect, and we abandoned the case. A word about a single case which we have a residual shunt. This was a patient with an aneurysmal septum with multiple fenestrations. We used the 35 mm cribriform AST device, and the residual flow was at a point where the device abutted the aorta, a very transient one where we couldn't coil or put an additional device. So this patient remained on anticoagulation. Our experience with imaging guidance, I'll share a few videos, but it's been predominantly TE. And this is a typical procedure which takes less than 10 minutes. You pass a BFO, you pull it from the SVC down, you observe with the wire crossing and then the sheath, then you deploy the device under TE guidance and assess the stability, release the device. In LAO cranial view, that is how you would want to see the device in profile. And this is the post-procedural TE pictures showing the nice straddling of the device on either side of the septum with no residual shunt. An occasional case where you used ICE guidance to deploy the same, the end result being the same. Now, after an angiographic profile, what do you want to see? You want to see a profile like this, what is called the cartoon pitch, the Pac-Man sign, where it bites into the thick septum secundum and a narrow profile of the septum primum, and that is what commonly is called the Pac-Man sign. And what happens to these patients? So in our series, if you looked at from 3 months to a period of 33 months, you can see the clustering of dual antiplatelet therapy and anticoagulation in the initial 6 to 9 months. But as you go on, time goes on, either they become free of all antiplatelet agents or a single antiplatelet agent at the end of 24 to 36 months. To summarize my slides, who would I do a PFO for? A recurrent stroke patient. If I find a secondary cause, I'll treat the secondary cause. If no secondary cause is found and there is a PFO, I would like to see for high-risk features a more than a mild stent, I would advise a PFO closure for this patient. As for guidelines, this was before the 3 new studies. It was a 2B indication. My take-home message is a cardioneurology team. Here is one scenario where choosing the case is more important than actually performing the case. The second, I would interrogate the patient with a TE and a contrast bubble for optimal evaluation. Third is a simple procedure, hence wants greater attention to detail to avoid complications. Thank you.
Thank you, Dr. Vijay, for a nice presentation. Very nice to know that so many patients are being referred by the neuro team to CMC, and they are doing good number of cases. I think it's all because of the awareness of depends on the awareness of the neurologist, because they are the main referral people. And I think technically it's very simple, but question identifying the patient who will benefit, that is more important. We'll have some discussion later. Go ahead for the next presentation. Thank you.
Big guest.
Dr. Hajra will be speaking on LA closure in non-valvular AF.
Hello, morning. I'm Hajra. My topic is LA closure. Is it for all? Let's go for some damn statistics in non-VAV. Out of 100 non-VAV, 15% patient will form clot in left atrial appendage. Out of these 15%, 91% clot will be in LA. Out of 100 strokes in non-VAV, 50% clot will arise from LA, rest from other sources. Out of all ischemic strokes, 15% are due to atrial fibrillations. Out of 100 embolic event in A, 75% from LA. Out of 100 clots in LA, how many will embolize can cause stroke? All, some, but till today there is no data. Now, LA closure, is it for all? The answer may be yes. You're dogmatic. Answer may be no too. You're again dogmatic. Answer may be diplomatic, maybe selective, optional, patient choice, doctor's choice. It could be like this, not at all a recommended therapy even for some non-VAV. Forget all non-VAV. I don't perform LA closure, so I'm not the right person to answer this. I have read all literature, all trials of LA closure. It should be stopped immediately, like TCD 2017, Dr. Mandrola. It's good, but not cost effective. Serious complications during procedure, so not ready for the prime time. I don't do it, so do not recommend even patient wants it. Again, dogmatic. I'm doing it regularly without much complication. Within 10 minutes, I can finish the procedure. So I recommend for all non-VAV. Again, this is intellectual conflict of interest. Guidelines are confusing on recommendations of NOAC in CHAT score 1 transatlantically. For example, even US you have CHATS 1, you have 4 choices, and US you have 2 choices. In Europe you have 2 choices. LA is a far cry. Warfarin is the best and cheapest panacea. Forget about the technique. If you go by the CHAT score itself, though it has got a lot of gaps, CHATS is just a number. Patient risk may be more with the same CHAT score, but tragedy is, the higher the CHAT score, higher stroke, higher death. But higher you have the CHAT score, the least likely to get the NOAC, warfarin, or and in this group, LA closure may be a choice. Now, in 2018, the world is facing 2 problems in emergency. Mostly warfarin-related problem, another is hypoglycemia-related problem. Next is road traffic accident. So in this situation, when you do not see the warfarin problem, LA closure is a reasonable and holistic choice. It's a one-time investment for lifetime problem of stroke and hemorrhage. Ultimately cost-effective at 5 years in US and Europe. Do it and finish the switch and switch off game of anticoagulation. One-time solution for intolerant, non-compliant patients. High CHAT, as I mentioned, should do LA closure. Best solution for breakthrough stroke while on full dose of VK or while on good dose of NOAC, best NOAC like Apixaban and dabigatran in full doses. Equally eligible for oral anticoagulant LA closure, but patient and physician choice, as I mentioned, kill 2 birds in 1 stone during AF ablations, mitral clip, or annuloplasty. A double trouble of stroke and bleeding with triple therapy in elderly in ACS, post-PCI, post-TEMI. Benefits will be much more pronounced than what we achieved from the PROTECT AF trial. It's a choice in recurrent GI bleed, unknown GI bleed, non-traumatic intracranial hemorrhage, amyloid angiopathy, subdural hematoma, dialyzed patients, renal dysfunctions, where the gold standard is warfarin without having a single RCT on warfarin or NOAC below 30 ml. During laparoscopic thoracic surgery, during mitral valve replacement, so excision is the best, not the ligations. Some surgeons are doing it. So if you do surgical ligation, it reduces blood pressure by 20 millimeter. So it could be a choice for uncontrolled hypertension, but there is no RCT data on liver and gastric varices. So what are the weaknesses of NOAC? Could be strength of the LA closure. Doctors always prefer low dose of NOAC, surprisingly available in US and Japan, 75 dabigatran. Only 50% of the world populations are anticoagulated in spite of profound knowledge of evidence-based medicines, confidence-based medicines, vehemence-based medicine that you reduce death. 70% of them discontinue. OAC, like any other boring antihypertensive, boring anti-diabetic, you have to take twice in a day, lifelong. Major bleeding 3%, death 5% due to ICH. So LA closure will reduce the number of ED visits for oral anticoagulant trouble, will reduce the number of outpatient visits to a chamber, will reduce the repeated boring, needle prick for blood test, hemoglobin, PT, APTT, etc. No need to wait for extremely costly drug for reversal when you land up with accident or you are waiting for emergency surgery. And at liberty to use thrombolytic therapy when you are facing with STEMI, because if you are facing STEMI or a stroke, you have to reverse this agent before you give thrombolytic therapy. So TPA is much more comfortable when you reverse it. But if you have LA closure on board, whether you have a stroke or you have STEMI, life is much more comfortable. So again, it is the evidence-based medicine, confidence-based medicine, and vehemence-based medicine you practice. And sometimes patience is a virtue. You wait for more data, you wait for more RCTs, more meta-analysis, and more number of patients done in India. You are wise, not a fool like me. So there are people who are a non-believer for PO4 closure, for TAVI, like I do TAVI. There are some non-believers. Who cares? There are some non-believers of LA closure, like Mandrola, even in US. So he thinks that it is bad. But is there any signal that LA closure may be less effective in patients who cannot take anticoagulation, won't take care of stroke? There is none. Dialysis renal patient, there are a lot of trials which have shown that placebo is weaker than warfarin, warfarin weaker than NOAC, NOAC weaker than LA closure in PROTECT A. NOAC is superior than VKN, far superior than putative placebo. What is putative placebo? You take warfarin placebo and compare with LA closure, because in real world you cannot do any trial on LA closure or NOACs on placebo. This is unethical. LA closure far, far superior than putative placebo or warfarin 6 trial. So these dialysis patients I have mentioned. So there are a lot of trials which compared warfarin with placebo and warfarin with NOACs and LA closure in RCTs. But the LA closure trial beauty is you can also the CV death. So if something reduces death, this is the most important thing in your practice. And it is the longest follow-up trial in any atrial fibrillation so far in PROTECT A. We have 5 years follow-up. But so far there is no placebo, but we have meta-analysis. Even the meta-analysis versus placebo, LA closure is superior, and it reduces 64% chance of stroke and death. So NOACs are leftist, warfarin are rightist. So if you go for Watchman, they are more leftist than the left. So in the forest plot, you have more benefit. It's cost effective. And now if you argue against LA, you have Prevail. But if you want to argue in favor of LA, you have PROTECT. But two trials are different. The age, diabetes, prior strokes. But in this trial, if you quote Prevail trial, the incidence of stroke is very small. So not a nicely conducted trial, only one stroke in the placebo arm. And nowadays, you have more confidence, more training, and it is very safe and safer than what it was in 2010. And over the years, LA closure has shown us non-inferiority. They have crossed that margin. Now we have data from PROTECT, 39% lower of primary endpoint, all-cause stroke, and death, 54% reductions. And what these trials have done, if you talk about warfarin, 5.1%, antihypertensive stroke reduction 3%, Jupiter on statin 0.3%, and look at the PROTECT A. 2.6% reduction of absolute stroke. You have problem with the CHAT score, so don't put all patients based on CHAT score. Use your common sense that if somebody needs an LA closer or a NOAC, give it to them. Creatine is not considered in CHAT score. Smoking is not considered. LA morphology, the warehouse, LA velocity is not considered. Lobes, chicken wing versus non-chicken, not considered. Race, not considered. Single dab, double pad, not considered CHAT score. Polypharmacy was not considered CHAT score. So one score is not the gold standard. So what about the guideline? So if you talk about guideline, they'll confuse you further. 2016, 2B, and ESC says those that need anticoagulant but cannot take anticoagulant. FDA says who can take anticoagulant but won't take it. American stroke is the most confusing. There is good evidence, but we do not know much. Nice. We can work it together, cardiologists, neurologists, no hard and first route for LA closer. And they give this, that the sample size of LA is small, and non-inferiority margin they have cleared 2, so easy to cross. But in this RCT, you do not find a single RCT on anticoagulant ineligible patients. All these patients are all common patients. So how come the US FDA allowed a trial? If somebody is ineligible for warfarin, how can he be eligible for 45 days of warfarin in Watchman trial? So these are the weakness, but whatever has happened, happened. But one thing has happened, that NOAC and LA closer, they have conquered the warfarin, which was there in 1952 as a rat poison. For some people, like this elderly lady who can enjoy her life with skiing, contact sports, it's a choice for them. It's not the oral anticoagulant. He would have been barred from this monkey jump. So if you win, you can lead. If you lose, you can guide. So LA closer, I think, as time has come, it can be offered in plenty of patients. So catch me if you can, the LA closer. Thank you very much.
Thank you, Dr. Hazra, for excellent talk. I think it's suddenly all this LA closure, everything has come down, but there is a space for selected cases, and individual can choose the case where the patient is not willing to take or patient is not very compliant with the medicines, and other patients of having bleeds. Yes, these are the cases where it can be safely used.
Yeah.
And it's a very nice device, and not little few cases. If you do, you can do it 4 or 5 cases. You can do it independently. Thank
Yes.
you, Doctor.
Doctor, what is the post-procedure protocol? How long you give antiplatelet or anticoagulant?
Look,
Post-procedure.
the antiplatelet, oral anticoagulant, there is 2.6 million probabilities. Duration, type of aspirin, dose. So, but to be very simple, all these LA closure can be done on aspirin, aspirin plus prasugrel, one simple NOACs. So aspirin plus clopidogrel for 6 months, then aspirin lifelong. Be it Watchman, be it ACP. In my practice, I follow this, not oral anticoagulant for 45 days as far as the PROTECT trial protocol goes. It can be done without warfarin. So my contention, if somebody is not eligible for warfarin, how can I give it for 45 days?
We have a lot of rheumatic patients, post-metabuloplasty. Do you recommend LA appendage closure?
Whole valvuloplasty, BMB.
Yeah, post-BMB.
The problem is if you do LA closure in moderate and severe MS, it's a contraindications, because most of these clots in annals of thoracic surgery, out of 1318 patients, 50% was in the LA cavity, not in the LA appendage. Now, these clots cannot be prevented by LA closure because you have 50% chance of developing clot in LA cavity. Now, if you have a BMB, if you do not have hemodynamic gradient, practically you are making it mild mitral stenosis. In those cases, actually I have one patient who has got mitral stenosis mild after CMB. She has undergone Watchman because she had a stroke, embolic stroke, hemorrhagic stenosis. It's a common sense. I mean, it's not a brainer that it cannot be used. Until unless you have significant mitral gradient, you can go ahead.
What are the complications incurred in your practice with this Watchman device? Which one you are using regularly? LA closure.
I didn't get you, sir.
What are the complications you encountered in your practice?
Antiplatelet, as I said, aspirin and
No, no,
clopidogrel.
complications with device-related complications with LA closure. You didn't have any complications with your device closure?
Complications?
Yeah.
With
Procedure-related,
antiplatelet.
post-procedure?
Oh, yeah. So nothing is without complications. I had one patient, and the second patient, I have done around 20. The second patient had embolizations because I was not able to check the Minnesota tag, and I could retrieve the device. I can put a second device. It is there in any learning cup. Like first two TAVI, I think, did not have complications, but third TAVI you had. So you never know when you come up with complications. But prepared with your knowledge, have discussion with your friends in India. Like there's a guy called Ranjan Sethi in South who has done more than me, and there are some guys in Vellore. You can talk to them over telephone that what has to be done.
Okay. Thank
So
you.
take help of friends.
Thank you, Dr. Hajra. Thank you very much.
you.
Now we'll go for the next talk. QFR, the new and useful alternative FFR, Favor India trial, Dr. A. Srinivas Kumar. I don't know because they have projected this. I think somebody else. Dr. Srinivas Kumar. Somebody else is.
Srinivas will be coming here by 10:45 is on the way. So my first question is regarding the first talk to Dr. Vijay. He said PFO closure in cryptogenic stroke. So what do you think the cause? Is it venous thrombus, and how do you give an anticoagulant antiplatelet on these patients prior to the device closure? Because it's a venous embolism, venous thromboembolism.
So the question to me is, do you give antiplate or anticoagulation?
Yeah, prior to the device closure.
See,
And
we
this-
don't change anything. We leave it to the neurologist because these are cases referred to us by neurologists. But after we do the device closure, we follow the standard protocol like how you do for an ASD, a DAPT for 2 months, and then only a single antiplatelet for around 6 months. Now, have I got your question, sir? Or is that something else you asked me?
Now, my question is post-procedure, because it's a venous embolism. Have you done the pulmonary pressure and looked for any pulmonary embolism in these cases?
No, these-
Because we are closed.
We don't routinely do it as a practice, unless the case where I mentioned to you the systemic embolism, where we done a PA angiogram, we did a CTPA to make sure there is no further. But as if you ask me for the other routine stroke, for ischemic stroke, I think we've moved away from anticoagulation.
Now the question is post-procedure device, the atrial fibrillation rate is around 3.4% according to the studies. So what is your...
See, I have a different take because it is around 5.7% in the closure trial, which was one of the most largest. Now the current device varies. So with the long-term data, some are immediate peri-procedural. The answer to your question is probably we know that the trends are more, but we don't know how long it is too long. Only time will tell.
Does all types of PFOs are suitable for device closure, or any subset like one you had a residual shunt where you can't close successfully? Is there any echocardiographic features which say that you may not be able to do successful job with device closure? Any such features?
See, most standard garden variety PFOs, you can close it. The one which I had was like a sieve, a large septum with multiple holes. And on one side, there was a 10 mm defect. So I used a 35 mm cribriform device and sort of plastered it. But if you see that it was snug to the aortic end, there was a little bit of a gap between the two discs, and it was leakage from there. So that, because I thought it is wise not to put one more device, especially looking at the anatomy, it was not suitable. So we decided to just continue anticoagulation. He's not had a recurrent stroke.
Dr. BG, for a young patient coming with AF with cryptogenic stroke, where there is a PFO, what will you do Will you close the LA appendage or close the PFO?
So, see, actually, you need to prioritize because if you know the risk profile of a stroke, first is the left atrial appendage closure. And then, if you think, then probably as you come out, you could think of a PFO device too.
My question is the other way. That is a paroxysmal atrial fibrillation, and that is one of the reasons for cryptogenic stroke. So, how did you exclude this entity before closing the PFO?
So it's very, very difficult. It's a very hypothetical question, which I don't think I'll be answering. There's not enough data. But looking at the hierarchy of stroke, if you say, because these are already established causes, mean your carotid stenosis of more than 50%, your atrial fibrillation are known. As of now, PFO is just getting there. So when you treat wise, also I think I'll stick to the same hierarchy of regime.
How many cases you have done with migraine?
Pardon me?
How many cases you have done this PFO closure with migraine?
See, we had, I think, 3 cases, of which all were complex with aura. All these patients had transient giddiness and a fall. Some of them had hemianopia transient while they were driving. One patient complained that he couldn't see the right half. So all these were complex, but none of the garden variety.
Let us ask regarding because we have some more time for discussion. So, LA appendage closure, now we have some literature showing that is a complication rate, like say thrombosis is high. What is your thrombosis at the incomplete closure and the thrombotic occlusion rates?
Thrombosis of what? You talking about ischemic stroke?
Yeah.
Oh, yeah. So there is only one thing against LA closures so far. If you go by this Prevail, there were, out of 100 patients, the incidence of stroke in the placebo arm was 1. So there is a serious discussion why it was so low. And the type of patients like diabetes, the age, and in spite of having high CHAT score, why the ischemic stroke was low, and as low as just 1 patient. And it is a small trial. But if you do the meta-analysis, like the patients who had only LA closure versus nothing on the other arm, by Dr. Reddy, by Dr. Spikia, there are a lot of people there, about 1,000 patients published in International Journal of Electrophysiology 2015. There, the ischemic stroke, hemorrhagic stroke, was reduced by 50%. So if you really want to see the negative side of LA closure, there is no reduction of ischemic stroke as per some trial by Protect and Prevail. But in real world, the things are changing, and it is the problem of the analysis of the RCTs rather than actual incidence. I agree that in those trials, the ischemic stroke was not reduced. Even in NOAC's trial, the incidence of ischemic strokes are not reduced because the ischemic strokes, there are so many co-variables. For example, if I talk about heart failure trial, anemia, thyrotoxicosis, age, ischemic heart disease, there's so many variables. For ischemic strokes, there are so many variables. For hemorrhage, the variables are very little, either hypertension or a trauma or a drug, usually embolic, like TPA or warfarin or NOACs. But ischemic so the variables so much, like indigenous atherosclerosis, there are small emboli, hypertension, smoking, there's so many variables are there. So that's why it's very difficult to prove. I think Srinivas is here. He's on the phone.
Yeah. Thank you, Dr. Hajra.
Okay, thank you.
Now we'll move on to the next lecture by Dr. A. Srinivas Kumar on QFR, the new and useful alternative to FFR, the Favor India trial. Dr. Srinivas Kumar.
Yeah, respected chairpersons, my dear friends, I thought the third person is coming here, that's how it's scheduled. While coming back, it got slightly delayed. Sorry for this delay. Now, what I am proposed to talk in coming 10 minutes, 15 minutes is basically to discuss another new exciting technology of quantitative flow ratio. We know FFR, when we talked about IFR, that was supposed to be talked in detail in the previous talk. But this QFR is another exciting technology, which I feel is disruptive technology in the sense that it is very patient-friendly, very useful for patient, no wires, no problems, no problem of having a bigger guide catheter. Anybody who can do a good angiogram, this amazing technology shows that you can assess FFR. That's what we did live demonstration before, and we should show it again. So basically it is a computer-generated functional assessment by volumetric reconstruction of 3D angiographic pictures and two contralateral views. This slide brings best features from Citizens Hospital, where you just saw MyVal TAVI program, which we delayed. Proud to present our group, which I mentioned before. And this is QFR analysis is basically an estimate of FFR based on fluid dynamic equation emulated by hyperemic flow velocity. I initially was surprised how this is happening when they were doing it on CT FFR. But it used to take a lot of time. It was sent to US and they send analysis comes after 48 to 72 hours. But we thought, why can't we do it on our cath lab table? We started working with the IIIT team here. We started doing the peripheral angio pictures, and they tried to do it the peripheral. Then meanwhile, our good friends of Angiographic Core Lab from Medis came out with this QFR software already. So this basically, slides do not move. This is a picture where you see the narrowing assessment, diameter stenosis, which is normally calculated by QCA, which is there in all our labs. And we may not go directly by it, but we used to get indirect evidence and decide our stents by that. So this little extension of that, and this is what is FFR, which you all know, that proximal distal gradients is done through a wire. Now it is well established itself. The limitations, as we know, it's invasive, sometimes adenosine causes problems, time consuming, and a lot of other issues apart from the cost which is there. Now with this three-dimensional reconstruction, it basically calculates and gives FFR, the QFR value. The diagnostic accuracy was compared with this. So what is this technology is doing is once the artery is three-dimensional reconstructed like this, and then other thing is wherever you want, you can get the FFR value. This is the cursor. If you have two lesions, then you probably want to calculate here as well as here, which was always a problem before, though we used to manage it for withdrawing. All that is also taken care by this new technology. So immediately it takes two views. It's a computer also suggests you 24 degrees angle views what we need to take. And then this is how the three-dimensional reconstruction comes, and it directly gives a value. This is the Medis software. There are other things which are coming up also in the other places. Once you get a value, then you're through. So this is called as index QFR, and the vessel QFR below, and the lesion. So we can assess exactly the main utility also will be in the multiple lesions. This is initially validated by initial trials through FFR versus FFR QCA. This is favor pilot 2 trial, and it was done, published in JAC. Then more and more data is coming up. This is a correlation basically with initially with the fixed flow, then contrast, then adenosine, all were being compared. And I'm not going to too much statistical details, but it is supposed to be agreeable up to with the sensitivity specificity values of around 85 to 90%. So the clinical, the way same diagnostic good accuracy pictures, now they plan to show this FFR favor 2 Europe trial, then functional assessment by virtual online reconstruction. That's what initially Europe, Japan was studied. QFR has a superior sensitivity and specificity for detection compared to QCA, and with FFR also being taken as gold standard. Stable patients were initially tried because now the latest data also showed ACS MI, but initially it was tested in stable patients, evaluation of non-culprit vessel stenosis after MI. Exclusion criteria, obviously any contraindications for it were excluded. Then angiographic inclusion, moderate lesions, obviously 30 to 90%, reference vessels being minimum of more than 2. Then this was tortuosities, hostile locations were excluded. Then the sensitivity and specificity was up to 88%. Then with initially positive predictive value, negative predictive value compared to what it was coming also was compared. Another thing is when putting FFR wire, obviously we all know that it takes some time. Sometimes wire is not as user-friendly as the routine PTC wire. It's slightly more stiffer. And there is some data which came up that it could produce some plaque ruptures and complications too. Not only without complications, the time for calculation was also much less. This was significantly less compared to the FFR, which is obviously it will be less because it's only diagnostic pictures coming up, and the senior tech calculates all this difference. Then, so in the areas where it is very clear cut, I strongly feel like this now. The areas where it's very clear cut, then probably you can avoid doing FFR totally. In these borderline areas, again, still till you get more confidence, probably you can still sometimes assess by invasive wire. So this trial does concluded, favor Europe-Japan trial concluded, showed that then this FFR has a superior sensitivity and specificity compared to QC, obviously, and also it has a good correlation with FFR with a faster time of calculation of QFR. So what they proposed is we need to have a randomized trial further to see the follow-up events, how it was done in the earlier trials with FFR, to see that patients in which nothing was done when the values were higher, how they are behaving. That's where the thought process is going on. Favor 2 happened similarly in China. Diagnostic accuracy of angiographic quantitative flow ratio in patients with the CAD was basically same again, three-dimensional reconstructions giving you the value. To evaluate this similar goals, about 300 patients, the statistical analysis showed you need to have 308 patients were taken, and then both online FFR, wire FFR and QFR were compared. And then if you see, then again accuracies were very good, and about LAD, LCX and RCS also they tried to compare, and most of the things it correlated quite well. Then the same thing, if FFR was more than 0.8, most of the times QFR was also more than 198 in 198 patients. And when it was negative, then this was also negative. The minimal offshoots were there. That's where I think sometimes confusion could happen. So this concluded saying that Favor China also concluded that it demonstrates the clinical utility of QFR in the diagnostic catheterization laboratories, and it could have a potential role to replace FFR. Then they went on to study this even in acute MI, assessment of null culprit vessels. That's what it recently got published in Circulation, just copied it. I also showed that by this way, 1 year follow-up, the vessels which were left with the QFR values were more than 0.8 and patients did all right. The various other trials are also being planned, and one of it I am happy to say that Medis agreed to partner with our foundation when we're starting Favor India trial. We wish to do it as a multi-center trial comparing FFR with QFR and borderline lesions, and about approximately 300 patients and 10 sites were selected. And data acquisition was done by each hospital, and then it will be analysis will be done with Central Fax Medis Core Laboratory in our hospital. Then we'll plan up for also follow-up analysis and to see how these patients were behaving or negative or positive up to 1 year. To give some case examples before I close, there are sometimes how it is very useful clinically, we can see by this. Here, the pre-picture was not there. We stented it across, crossover stent, and then we wanted to assess the lesions then the LCX circumflex lesion came negative, 0.92, so we left that without treating. And then there's another example. I think this is a total occlusion of LAD with some mild proximal disease also near the left main. So we opened up the vessel here totally, and then whether to stent it and make it more complicated because it comes onto the left main. We thought we would assess the lesion after putting a stent and taking it here. That's how the calculation of QFR was done, and then it came like 0.85, and we did not do it, left the patient. So that's how even this procedure has a lot of advantages. What we were doing it with wire, now we can have it without wire with just three-dimensional reconstruction. The fluid hemodynamics calculations are supposed to be based on that. Only precaution is you need to get a good angiographic pictures and probably pre-treat the vessels with nitroglycerin, like how we do it in any proper imaging. And getting a good angiographic picture is imperative and a must to calculate this QFR also. And we need to be careful in looking the lesions and how to profiling the lesions. That's the only precaution I feel we need to take. But now, to conclude, basically it says that it's the most fastest computation of FFR on the by computer-based software, and there's no need for adenosine, and then use of QFR. Sometimes only problem is technicians and the picture should be good. And currently we are doing it on stable patients, but in future, if you can assess further, diffuse long lesions, MI bifurcation lesions, wherever you want to trace the artery and find out at that particular point how it is important, all that is possible. So obviously, as we recapitulate before we close, benefits of QFR for patients: no adenosine, no side effects, no extra radiation, less chance of complications due to wire insertion, nothing is there. For interventional cardiologists, even with diagnostic catheters, we can get the QFR values, no need to put a guide, wire, etc. Then same time, one stop, you can calculate the lesions and tell the patient. Sometimes in clinically, we were forced to call them reassess again, do stenting later. All that would go away gradually if it proves again further. And for hospitals, it will be very cost effective. And the same software, if it is there in the cath lab, I wish in future it should be a part of every cath lab, so that like how we practice QCA today, QFR could come into guidelines if proven more. And if any patient who has a QFR value of less than 0.8 only should be treated with stent, something like that can come, it will prevent a lot of abnormal criticism, and some unnecessary procedures also could be avoided. So I feel this is truly disruptive in the sense that it's good for patients and good for cardiologists, and probably in future, once it is proven, we can make it mandatory pre-PCI documentation of this value before you do a PCI. Thank you very much for patient hearing.
Thank you, Dr. Srinivas Kumar. We have time for 1 or 2 questions. Anybody like to ask about this QFR?
Dr. Srinivas, how do you produce hyperemia here, downstream vessels, hyperemia in the small vessels? How do you exclude the microvascular dysfunctions and spasms?
No, if you want to test it that way, you can do it. But what we are basically doing it is the contrast is acting, and then we inject nitroglycerin to prevent spasms, and then take pictures like how we do baseline angiography. That's all.
You give intracoronary nitroglycerin.
Then, if you wish to test that way, we can also, we're not directly, we can inject adenosine and again take a picture, but all that is may not be required. That's what is thoughtful.
Have you done this multi-vessels in left mains?
Sorry?
Multi-vessel, borderline lesions in multi-vessels.
Same thing, you can calculate QCA, you must have done it on cath lab.
Yeah.
So simple, wherever you want, you can calculate. You can calculate in the same picture to LED. Again, you can change it, and that in the live demonstration today afternoon, what we are planning to show multiple long segment diseases in LED and then RCA with some critical stenosis in LCX. That we would like to show. Same thing live. Last time in TCT meeting also we demonstrated live. It came out perfectly same like invasive FFR. So the beauty of it is like whoever can take a good angiographic picture, that's it. Nothing else is required. Only the computer is calculating 3-dimensionally. But only thing is we need to have proper 25 degrees separated 2 views which show the lesion right. That's the only prerequisite. If you can get that, nothing else is required.
Borderline left main, have you done these cases? Borderline left main disease, left main.
That's what we need to study further. As of now, I would confess that we have not done many cases. But in the earlier studies, the osteal diseases were and tortuous visions, where the image is not proper, were excluded. Obviously, the limitation would be wherever you don't get a good angiographic picture, which showing the stenosis. Obviously, you can't get a good, because it's basically working on the 3-dimensional reconstruction of the angiographic pictures. So if you need to have a good picture quality to get this, that's the only prerequisite. Obviously, to do stenting or do any intervention also, we need to have a good picture. Advantages I thought is no need to wire, and even the same diagnostic 5 French catheter, you take picture, you still calculate it.
Okay. Just like a catheter tagged to the diagnostic catheter.
Yes.
Just,
so it will be an extension of angiogram.
Looks very interesting and makes things very simple. And there are already many trials in Europe where it's being proved that just like FFR is almost same as FFR.
Yes.
So I think it has to be integrated to our daily practice, and which will be done soon. I think it's very good. Thank you, Dr. Srinivas.
Thank you, sir.
Okay. Thank you, Dr. Srinivas Kumar. I think we'll
Excellent
close this session.
We close this session.